Madam has completed her DM Neurology from the prestigious institute PGI Chandigarh. Presently, she is working as Professor of Neurology at Dayanand Medical College, Ludhiana. Madam is also highly academic with 54 publications in indexed national and international journals, and has also authored individual chapters in various books amounting to 15. Madam's special areas of interest in migraine, stroke, and neuro-ophthalmology. Madam is also keenly interested in conducting quiz, and for which she got award also, both in Chandigarh as well as in Ludhiana for 6 consecutive years. Madam also has received awards from various houses like JCI, SDFC, and Punjab Youth Government in 2020 and 2021 for managing COVID patients. So with this, we are very proud to host Dr. Monika Singhla to share her experience and expertise in migraine management. Over to you, madam. Thank you.
Thank you, Shankarji, for your kind introduction. So let me share my slides. Are my slides visible?
Yes, ma'am. Yes, ma'am. Visible, ma'am. Visible. Make it large.
Is it okay?
Ma'am, it's small. Make it large, ma'am.
I have done the full screen.
Ma'am, from down it is there. From down it is there.
I'm doing from there only. Is it full screen now?
No, ma'am.
Okay, let me try again just once. So can you tell me now it's full screen or not?
Yes, ma'am. Full screen. Now it is full screen.
Full screen?
Visible.
Okay.
So it's not visible.
Sorry?
Not visible, ma'am. Not visible. Full screen, but not visible. Make it small, ma'am. Let it be small. Let it be small. Fine, ma'am. Fine. It is fine. This is fine.
Visible?
Yes, fine, ma'am. Fine. You can continue, ma'am.
Okay. Good evening, everyone. Diagnose and manage. I think it's very common topic. Everyone must be thinking that what's new in migraine. But I think migraine and headaches, they make most of our which the name suggests that half the skull is aching. And the earliest description, as I told, that we have come from the 3000 BCs. In early years, the people used to do that. They used to trepanation. They used to take out the blood from the head and from the other body parts to control migraine. And if we see this timeline of migraine research, we know that since 1918, these ergot alkaloids came into the picture, and gradually they were used in migraine. Then we have the other molecules, CGRP antibodies over time. We have our beta blockers, we have our triptans. So this central spreading depression. So all these things came into the picture as we started understanding the pathophysiology, and accordingly we have the innovation of these medications. Migraine, it affects the majority of the individuals. About 1.37 billion individuals are affected with migraine. And we know that it's much more common in women, 3 times more likely to be in women, and more common in the young people. But as people get old, it's more associated with disability of the migraine. Migraine is not only a headache, it's a spectrum of disorders. We need to understand that there are many symptoms, there are many associated comorbid conditions of migraine. People can have multiple features. When they have migraine, it's not only headache. They feel fatigue, they feel low in energy, difficulty in sleeping. They can have depressive symptoms sometimes. Some people have anxiety, stress, and they have a lot of anger, irritability. Pain can be general pain, or there can be just a sensation of pain. Sometimes they just deny that we don't have headaches, but we just have heaviness of head. It can lead to the reduced employment, general physical and mental health is affected, social functioning of the people are affected. Sometimes they start avoiding the relationships and family activities and get-togethers. So migraine has a lot of comorbidities, and sometimes there is no impairment, but sometimes there can be impairment of with the migraine. Depression, as per the study of America, there's a depression which is associated among the people with migraine. They can have low frequency, moderate frequency, or there can be high frequency of chronic migraine. So depending on the frequency of the migraine, whether it is episodic or high moderate frequency episodic, accordingly depression can be more. With people who are having chronic migraine, depression is much more associated with those people. Migraine, if it is such a common disease and it affects people and leads to headache, so we understand there is a lot of economic burden. What are the direct and there are some indirect costs of migraine. Direct costs. Keep everyone on mute. Can the host do? Thank you.
Yes, ma'am. Done.
Yeah. The economic burden of migraine, we need to understand that there can be direct cost involved, there can be indirect cost involved. Direct cost means we know that we have to purchase so many medications, we have to buy prophylactic medications, painkillers, SOS medications. Sometimes we have to go on monoclonal antibodies. Some people have to go for Botox therapy. There are so many things. So direct cost, but there is a lot of indirect cost involved because there are many reasons. These people have comorbid conditions, they have depression, they have to consume other medication, they're not able to work, they're losing their productivity of life, they have to take leave or they're absent from their workplace. So again, it increases to the added cost, indirect cost. So we need to increase knowledge and access of effort management to reduce this economic burden of migraine. So how do we classify? I'm just going through the primary headaches which we are dealing in routine, but I will mainly focus later on migraine. So primary headaches, we know that is migraine, tension type headache, trigeminal autonomic cephalgias, and there are other primary headache disorders. Secondary headache, when we say that is secondary headache, because every headache is not migraine, but yes, it is the most common headache. Secondary headache means when it is secondary to some other reason like trauma, due to injury of the head and neck. It can be because of some cranial pathology, it can be because of some cortical venous thrombosis, because of stroke, because of infection, meningitis, some brain hemorrhage. So there are many other reasons, and even head and neck infections like some fungal infections or some tooth infections can lead to headaches. And there can be facial cranial neuropathies and facial pain. So in primary headaches, we have migraine, tension type headache, this cephalgias and other primary headaches. Migraine, we know it can be without aura, with aura, can be chronic migraine, and then we need to understand complications of migraine and probable and episodic. How we define migraine without aura? Commonest type, which is the common migraine. When patient is having at least 5 attacks fulfilling this B to D criteria, that is headache attacks lasting 4 to 72 hours. Obviously, when without treatment, because headache can be treated within 1 hour if we have taken analgesic, but without treatment. And headache has more than 2 of the following characteristics: unilateral location, pulsatile quality, moderate or severe pain, aggravation or causing avoidance of routine physical activity, like walking or climbing stairs. Third thing, headache has more than 1 of the following, like nausea, vomiting, and photophobia and phonophobia. And this pain cannot be accounted by any other ICSD-3 diagnosis. So when patients, we are dealing with migraine without aura. Migraine prevalence, as I told, it's much more common in women. So if we have a lady who presents with unilateral right temporal headache moderate to severe in intensity, which builds up over 2 to 3 hours, gets nausea, vomiting. He to lie down in dark room. Frequency of these attacks is once in 7 to 10 days. And she has some triggers: hunger, sleep deprivation, coffee intake. So diagnosis, migraine without aura. Migraine, as I told, initially can be episodic, but sometimes it can go into the chronic phase. Second is migraine with aura. We know that migraine has many types of auras. It can be in the form of visual, it can be in the form of auditory, sensory, somatosensory, or it can be motor aura, but most common is the visual aura of the migraine. So migraine aura can be in the form of tachopsias, or it can be in the form of scintillating scotoma. So this type of patient will present with, if some patient present with right eye scintillating scotoma, which builds up over 5 minutes. And this scotoma, it lasts for 25 to 30 minutes. And it's followed by unilateral headache, which is as with nausea and vomiting. Then we know diagnosis is clearly migraine with aura. But yes, migraine with aura, sometimes we have to keep as a diagnosis exclusion. But if we have recurrent episodes, then we know it's migraine with aura. But if it is the first or the second episode, then probably we need to rule out some underlying pathology if patient does not have that classical headache or typical aura. Again, how we diagnose migraine with aura? If patient has more than one of these symptoms of visual, sensory, speech, motor, brainstem, or retinal aura, or more than 3 of the following 6 characteristics, that aura gradually spreads over more than 5 minutes. If it is very brief, rapid episodes of vision loss, then probably we are dealing with TIA. It's not aura. But if it's more than 5 minutes, lasting for 5 to 60 minutes, and reversible, then probably we are dealing with migraine aura. And there are more than 2 symptoms occurring in succession. More than one aura symptom, which is unilateral, positive aura, not vision loss, but it has zigzag lines or scotomas. And aura is accompanied within less than 60 minutes by headache. Then it's migraine with aura. Hemiplegic migraine, we know that fully reversible motor weakness, or sometimes fully reversible visual, sensory, or speech. Retinal migraine, when we say retinal migraine, if patient is spreading gradually, this fully reversible monoocular positive or negative visual phenomena, and spreading gradually over 5 minutes, and symptom lasting for 5 to 60 minutes, accompanied by headache. Then we say it is retinal migraine. Tension headache is when there is a more than 8 days of headache in a month for more than 3 months, and continuous type of pain, which is lasting for more than 15 days a month. Or if there is a migraine without aura, and sometimes if it is lasting more than 10 days, but patient is getting relieved by triptan or ergot derivatives, then we call it as a chronic migraine. Complications of migraine, it can be status migraine illness if it is continuing without a break more than 72 hours. Sometimes there can be persistent aura. This vision loss episode or zigzag lines can last for more than 2-3 days, but there is no infarction in the brain. And sometimes migraine can lead to stroke also. There can be episodic syndrome. So now I will not spend time on these other primary headache disorders. Just quickly, this differential diagnosis of migraine, episodic tension type headache, or episodic cluster headache. We know that we are dealing with these 3 entities most common in our OPs. Migraine is much more common in women as compared to men. And even children before puberty, 4% of them can have headaches because they have a strong family history. Their parents have headache, children can get migraine. Tension headache, it's more common in 90% of adults as compared to children. Episodic cluster headache, it is much more common in men as compared to women. Family history, in 80% of the first degree relatives usually migraine, but I will say probably not 80, it's 100%. Many times people do not notice they have migraine, but usually it's present in every patient whosoever have headache or migraine. Episodic tension type headache is very frequent. Cluster headache, family history is very rare. Typical age, we know that usually migraine happens in a younger age, before 40 years. Very occasionally it can happen after 50 years. If it is after 50 years, then we know that it is red flag. And this episodic tension type of headache, it can be in the age group of 20 to 40 years, cluster headache again in 20 to 40 years. Migraine visual aura can be present 20% patients. Location usually unilateral, but it can be bilateral in the 40%. Episode tension type headache is usually bilateral. Cluster headache is strictly unilateral, always on one side, with orbital or periorbital pain. Quality of pain is usually pulsatile and throbbing in migraine, and it can be burning or stabbing in cluster headache. Severity, severe in cluster headache, it can be mild to severe in migraine. Onset to peak, usually minutes to hours in migraine, takes time to build up. Cluster headache usually happens in minutes. So duration of attack 44 to 72 hours, cluster is 15 to 180 minutes. Frequency, it's rare to frequent, but clusters usually happen, it happens in clusters. So we know that multiple attacks in a day, clusters. Other primary headaches I will not discuss in this presentation. So how do we manage? To manage migraine, first of all, diagnosis is very important. So as I mentioned the criteria, if we understand the criteria and patient's history, examination, then we understand what is migraine. If we have made a right kind of diagnosis, then we need to see other factors like control trigger factors and lifestyle factors, how to give therapy, acute and abortive therapy, prophylactic medications, role of magnesium, medication. I'll just discuss all these entities one by one. But we need to understand that every headache, as I told, it's not migraine. There can be sometimes, occasionally, we may miss something serious cause. So which headaches can be, which are the features which will make us understand that it can be some serious cause. If it is very sudden onset, thunderclap-like headache, onset over a few seconds only, just like a blow to the head, and immediately patient has nausea and vomiting, then we need to consider this possibility of subarachnoid hemorrhage. And along with this, we know that this is severe neck pain and neck stiffness. If the pain is precipitated coughing, sneezing, exertion, bending, or Valsalva, then we need to rule out raised ICP. I think all headache patients we should do fundus, but people who are little obese, overweight females, they complain of any blurring of vision, we should always look for fundus to check for papilledema. We know that there can be venous sinus thrombosis, IIH, but there can be some tumor or abscess. If there is history of any previous malignancy and the patient comes to us with headache, then we need to rule out metastasis. New onset headache, as I told, in a patient with more than 50 years of age, they have never had headache in the young age, then we should look for giant cell arteritis. We should check for ESR, CRP, and always rule out some kind of malignancy. If any fever, drowsiness, rash with headache, then meningitis or encephalitis should be ruled out. If aura is atypical, as I told, usually aura has to last for 5 minutes to 60 minutes. If the duration is more than 1 hour or there's a motor weakness, then we should look for any stroke or tumor. Aura occurring for the first time in a patient during use of combined, like oral contraceptive pills are there, then we should look for any CVT or stroke. If there are eye symptoms like unilateral painful eye, visual impairment, we know that unilateral painful eye can happen in cluster headache but last for a few minutes. But if there's a visual impairment along with nausea, vomiting, then we should rule out angle closure glaucoma. These are some pointers which we need to understand that we are not missing these serious things. What are the trigger factors and the risk factors for migraine? Most important, I feel, out of these is relation with meals, relation with sleep. These are the two most important factors. People who do not have breakfast, who are taking their meals late, or they're missing their meals, then there's high chances that we can get migraine. Sleep. We are sleeping late, we are sleeping less, or we are oversleeping more than 8 hours, like 9 to 10 hours. It can lead to migraine. In females, periods, perimenstrual, premenstrual, postmenstrual, all these things can cause migraine. Even postmenopausal, they can have headaches. Weather, high, this kind of weather, like bright sunlight, hot weather, high altitude, humid weather can lead to migraine. Alcohol can lead to migraine. Some particular diets like cheese, curd, buttermilk, lassi, paneer can lead to migraine. Coffee can lead to chocolate, tomato can lead to migraine. Some particular medications like nitroglycerin can lead to migraine. Smoking can increase migraine, bright lights. And if somebody is having more of stress, anxiety, small stress, anger, fear, depression can lead to migraine. So how we control it? We need to change our lifestyle. We need to tell people that you need to sleep well, sleep in time, follow a time clock. because medication is not everything. We cannot keep giving medication for whole of life. We need to advise our people, and we all need to follow this lifestyle that we need to sleep well, 7 to 8 hours sleep, and at a particular time of time, early to sleep, early to rise is the best thing. Increase fluid intake, stress levels need to be managed, which can be managed with some mind relaxation exercises, yoga, meditation, walking. And we need to control comorbid conditions like obstructive sleep apnea. If somebody is snoring, they can have early morning headaches. So probably they need to be advised for the early meals and weight reduction. And sometimes people may require CPAP. And we need to control their hypertension. But we know that these lifestyle changes, they do not work in one day. These are for the long-term control of migraine. For the short-term control, when patient is coming to us, they're having severe kind of headaches, their attacks are severe, because once migraine happens, once attack has happened, then change of lifestyle does not help. We know that. Once, I am very clear, once headache is there, then you have to take a pill. Whether you sleep or you have your food, but once the headache is done, you have to take a medication. You may take immediately, then you will be fine. Otherwise, it may go on continuous headache for 2 to 3 days. Best thing is to prevent it, to have meals in time, to sleep well. But once the attack happens, we usually give the simple oral analgesics along with antiemetic. Some people prefer aspirin, ibuprofen, paracetamol. Usually we prefer naproxen plus domperidone combination, and many people, they are doing very well with metoclopramide domperidone combination. So we know that because of the prokinetic effect, it promotes gastric emptying and it helps more in this efficacy of analgesics more, and nausea vomiting is controlled. So usually 500 to 750 milligram, or sometimes we need to repeat 12 hourly for 1 or 2 days. Even diclofenac some people prefer, so depending on the patient's choice. But many times in the early stages of migraine, naproxen, paracetamol, or metoclopramide may work. But in the people who have severe attacks, they may have to go for triptans, and they feel comfortable that if they take one triptan tablet, rizatriptan or sumatriptan, they are better. So depending on the patient's comfort and requirement, we should use these triptans. Initially usually 10 milligram, but if you're using with propranolol or beta blockers with prophylaxis, then 5 milligram is sufficient. Sumatriptan, this rizatriptan is available in the tablet form and this strip wafer. Sumatriptan oral medication, subcutaneous or nasal spray is there. So it is again effective. Alitriptan, niratriptan, zolmitriptan. We are not using very frequently, but yes, zolmitriptan spray is there available. And they do require triptans once this naproxen domperidone is not working and they have long-term headaches. But we need to follow this contraindication because triptans are not safe for every patient, especially patients who are having cardiac disease, coronary artery disease, ischemic heart disease. So we should be avoiding these triptans. We should be careful in that case. Pregnancy, it's not safe. Patients who are taking myo-oxidase inhibitors or TCS, tricyclic antidepressant, or SSRIs, due to risk of serotonin syndrome, triptans are not safe. Specific anti-migraine medication triptans, usually we need to take patient who have migraine with aura. If people they're taking with during the time of aura, then it is not effective. Once aura is settled, just at the beginning of headache, it works very well. And initially 20-50% of patients who initially respond, they have a rebound headache within 48 hours. And some people may not work. And if they're consuming triptans very frequently, every day, some people keep taking twice daily, and then they have medication overuse. So they're not safe if they're consuming more than 2 days a week. And sometimes they can cause chest or neck or jaw discomfort and paresthesia, GI upset. If person, I think people who are having more than 4 attacks per month, or they are having contraindication to these acute treatments, or if there are more than 2 attacks a month but they are disabling, then we should start with migraine prophylaxis. It's much more safe, and sometimes they are taking 1 to 2 months of therapy and they're doing good. So in those cases, and if they have prolonged or uncomfortable auras, hemiplegic migraine with basilar aura, then we need to start migraine prophylaxis. Usually, many people, they do not take migraine prophylaxis. There's a lot of underutilization of migraine prophylaxis. But yes, people who come to hospital, they still agree and they take prophylaxis for the short term. And success of migraine prophylactic agent is when there's 50% reduction in the frequency and severity of attacks. We do not tell patients that they will be 100% cured, because they have to keep changing their lifestyle accordingly. But once in a while, when there is some stressor, they have to travel, they can get those migraine headaches. Prophylaxis, we need to select according to the patient, what kind of patient we are dealing with. We need to start slow and go slow. Give each treatment on the adequate trial at the maximum recommended dose. I will not say that every drug we need to give the maximum recommended dose. We get to know whether when we are starting the low dose therapy, if it is effective, then after 2-3 visits, after escalating, they are better. We need not to go to the every drug for the full dose to give a trial. But yes, if the patient is not relieved within 2 to 3 weeks or 1 month, we can plan changing or add on therapy. So what all medications are available? We have many different kind of category of medications. Anti-epileptic therapies, divalproate sodium and sodium valproate, topiramate. So according to patient is thin built, we can go ahead with divalproate sodium valproate. If patient has some kind of epilepsy along with some kind of depression or some kind of bipolar mood disorder along with headaches, then this is a preferred therapy. Topiramate in cases patient who are obese, little overweight, and women who are concerned for their weights, we prefer topiramate. Beta blockers, I think it's very easy to choose and very safe. Propranolol specifically, we use very routinely, but very low dose, because people who have low blood pressure, they do not tolerate high doses of propranolol. Triptans, as I told, they are mainly for the prophylaxis. Otherwise, many people who are having depression, they use antidepressant, like especially amitriptyline is very good, effective medicine, given at night time. People who are having chronic type of headaches, they have a little low mood, they have sleep disturbances, then amitriptyline can be more effective. But yes, we need to consider weight gain and dizziness in the daytime, sleepiness. Again, ACE inhibitors, some people use, but here we completely avoid these medications. We usually use divalproate, topiramate, propranolol, and amitriptyline for migraine prophylaxis. So, how do we start? Usually 10 to 20 milligram twice a day. Initially, we start with once a day, then we can give 4 to twice a day, especially morning and afternoons. We avoid giving propranolol at nights because it can lead to insomnia. And the target dose can be 40 to 80 milligram, but many people are doing good with 10 milligram or 20 milligram. Precautions, we need to understand that asthmatic patient diabetes, we need to avoid, and especially who are having bradycardia or peripheral vascular disease, we should avoid. Similarly, these beta blockers, they have the same kind of precautions. Then amitriptyline, usually we start with very slow, sometimes 10 milligram at night, but sometimes half a tablet. People are doing good with that also. But initially, gradually we can increase up to 25 milligram. Sometimes you have to go to up to 50. And venlafaxine, if there's some kind of depression along with, then we can start with 37.5 milligram. And we can go up to 75 or even sometimes 150 milligram. Pyramid, very effective medication, but they can cause a lot of paresthesia, tingling, needle-like of sensation. So we need to be careful. We advise people to take more of water, sometimes potassium-containing diets. But we need to be careful if there's a history of renal stones or somebody is developing renal colic, then we need to immediately stop topiramate, and ankle closure glaucoma can be precipitated, and we need to avoid in pregnancy and depression. Sodium valproate, again, obesity, liver disease, PCOS, women with pregnancy or childbearing age, we need to avoid. Otherwise, it's a good effective medication who have combination of epilepsy or bipolar disorders. These drugs usually we avoid, but recently we are using these vitamins and minerals, like especially magnesium. I think it is found to make a combination with our other prophylactic medications. I will not use magnesium as a single medication, sole medication, but yes, along with other medications. Then it is found to be effective because we know that we are just giving supplement and we can give for a long term. So patient is also not bothered about for the long term therapy, and I will also not be bothered because over 2-3 months, We can plan stopping our other prophylactic medications, and we can continue with magnesium. So let's just discuss 2-3 slides about role of magnesium in migraine, how this concept has come. Magnesium, we know that it's an essential macronutrient that plays a key role in many body processes, including muscle, nerve, bone health, and mood. An important cofactor in more than 300 biochemical reactions to maintain a normal muscle and nerve function. In the brain, it helps in nerve transmission and neuromuscular conduction. Magnesium also functions a protective role against excessive excitation. So it serves as a blockade to the calcium channel in the NMDA receptors. And low magnesium levels potentiate glutaminergic transmission, leading to supportive environment for excitotoxicity, which lead to neuronal cell death. So it's considered to be a neuroprotective agent and helpful in migraine, depression, epilepsy, chronic pains, anxiety, stroke, Alzheimer's, and Parkinson's. In cortex, we know that there is an NMDA receptor activation in migraine, which leads to cortical spreading depression. In blood vessels, there is a nitrous oxide regulates cerebral blood flow. Serotonin released from platelets includes cerebral vasoconstriction. CGRP stimulates vasodilatation and increases nociceptive transmission. So what does magnesium do? Magnesium is a voltage-dependent NMDA receptor blocker. So it reduces the excitotoxicity. Nitric oxide production is inhibited if magnesium level is low. Serotonin-induced vasoconstriction can be blocked by pretreatment with magnesium. And magnesium has been shown to decrease circulating CGRP. So I think it has a multiple actions if used carefully and wisely in our patients. We can make a good combination, so it can help. Past research has also shown that significantly low levels of magnesium were reported in the serum, saliva, and CSF patient with migraines. And reduces the glutamate levels, and it also investigate the relationship between migraine magnesium levels and headache, and in headaches, magnesium levels were found to be low. So overall studies have mentioned that the use of oral magnesium salt represents a well-tolerated, inexpensive addition for the treatment of headache patients to reduce the frequency of attacks and the cost of treatment, both in terms of economic burden and adverse effects. So we shall be discussing few special situations of migraine. Because all patients cannot be treated. The biggest challenge comes to us when the patient tells me, ma'am, I have headache for so many days and all. And finally, she will just tell that I'm pregnant. I'm 8 weeks pregnant, 4 weeks pregnant. So I think it's very, very difficult to manage these patients. We need ideally, I've seen that no prophylaxis is safe. All these medicines, they come in category A, B, or C in pregnancy. Magnesium, whenever necessary, can be considered in pregnancy. If there is some pure menstrual migraine prophylaxis, because some patients are very clear, they do not have any other triggers for migraine, it's only little periods, then obviously it's unavoidable trigger where we cannot tell them to change their lifestyle or anything like that. We need to, for this, we need to give prophylaxis and we need to give medications. So probably we advise them to start these medications 2 days before menstruation if they have a good calendar that they know when the periods will come. And these medications can be continued for 5 days. And perimenstrual NSAIDs can be given. Sometimes people prefer triptans. Even if it is not controlled with these medications, continuous hormonal therapies can be advised. They can have administration of an oral and estrogen progesterone oral contraceptive, and low dose estrogen dose can be recommended to reduce the risk of stroke. And for perimenstrual pain, estrogen for women having a natural cycle, if we don't want to give the combination therapy, then 100 microgram estrogen patch about 3 days before the onset of bleeding can be advised. And if there is a medication overuse, as I told that many people come to us once prescribed, if you do not tell the patient that this medicine, Vasograin, this triptans, they have to be taken not more than twice a week. Many physicians are writing, some people are taking morning, evening, twice daily for 2 weeks, 3 weeks, 1 month. Every time they're just consuming daily. And they come to us with migraine overuse headache. Next day, when there's a withdrawal of medication, they have the relapse of migraine attack. And every day severity is increasing. It's sometimes very difficult to manage on the OPD basis. We try to cut down medication, but sometimes you have to admit the patient to control their medication overuse headache. We need to start with prophylaxis, and sometimes they need a short course of steroids, and they have to be given good psychotherapy, and they have to be motivated to stop those medications. And triptans, usually it's a 7 to 10 days they have taken, so it can lead to headache. If simple analgesic more than 2 to 3 weeks, narcotic 2 to 4 weeks. So we have to withdraw the drug, and then probably we can give naproxen, which can be given safely, and we can start with the prophylactic medication. And we need to assess this patient after every 2 to 3 weeks. And most patients sometimes revert to their original headache type within 2 months. And then overuse medications may be reintroduced whenever required on the SOS basis. So how we use with according to the clinical situations. If the patient has first-time headache, then probably beta blockers are preferred or tricyclic antidepressants. If we want to have a low side effect strategy, then probably we need to prefer this candesartan, which we don't use. But yes, this supplemental therapies like vitamins, magnesium, riboflavin, coenzyme Q10 can be tried. Patients who are having high body mass index or diabetes, in those cases, topiramate or candesartan can be tried, because propranolol can lead to increase diabetic levels. Though we do not feel much problem, but still it can lead to. If there is history of epilepsy, then topiramate or sodium valproate. Hypertension we need to control, then probably beta blockers are the preferred therapy along with the calcium channel blockers. Depression, anxiety, or menopause, then we need to prefer for amitriptyline, venlafaxine, or propranolol. If there is a poor sleep, as I told, amitriptyline, topiramate, and sometimes people give pregabalin as well. For fibromyalgia, amitriptyline, pregabalin, they do wonders. Additional monotherapy, then probably if there's a beta blocker going on, we can add topiramate. Topiramate is going on, we can add to amitriptyline, or sometimes sodium valproate, or some other anti-epileptic drugs. A refractory patient, then we need to combine 2 to 3 drugs, but preferably with different mode of action. Many patients, they just tell that we do not want to take medication, and the headache is ongoing, severe, continuous type of chronic migraine. In those patients, we have the advanced therapies. Botox, botulinum toxin we are using in a department routinely. I have not used this KFLE device as of now, but CGRP monoclonal antibodies we are using. Botox is a quite effective therapy for people who have chronic migraine. Chronic migraine, as I told earlier, that more than 15 days a month or at least 3 months. In those cases, Botox is a preferred therapy, and we use Botox with this preempt trial. We have to give approximately 31 sites, including for this forehead, temporal, and the occipital area, trapezius also. So we have to give 31 different sites. So this Botox therapy is effective. At least patient will be quite comfortable, and chronic pain can go for 3 to 6 months. Then we can repeat it. And patients who are having they have other significant neck pain, people who have a lot of neck pain, occipital pain, they do much better on Botox. But there can be little side effects. We need to be careful that we have to be careful that patient doesn't develop any ptosis or something. Otherwise, Botox is quite effective. This CAFLE device is also a good thing because it leads to supraorbital transcutaneous nerve stimulation. As per this premise study, which was a randomized double-blind sham-controlled study, there was this regular neurostimulation daily for more than 20 minutes, and patient had significant change in monthly migraine days, more than 50% responded. So some people who do not want any medication, any injections, this CAFLE device can be effective and helpful. And another boom in the treatment is CGRP inhibitors. So this monoclonal antibodies, they are found to be effective in patients who are having As we know, CGRP levels increase in migraine sufferers. And during migraine attacks, these levels are high in migraine with aura, without aura. So these antibodies, they can be used. This Suvire, which was available earlier, there was a once a month injection. So people are doing good on those injections if they are given 3 to 6 month therapy. But major factor with these monoclonal antibodies, with Botox therapy, with Kefli device is the cost. Because many people, they are not able to afford that 30 to 40,000 of botulinum these monoclonal antibodies, which comes in the cost of 14,000 a month, 3 to 4 months. So they may not prefer these therapies depending on the cost issues. So we need to choose our patients carefully, wisely, according to their needs. I think there are many factors to choose a migraine patient, what kind of therapy we want to give, their migraine profile, how much their work is affected. Most important thing is to spend time on their triggers, their lifestyle. So if we guide them properly, that they need to change their lifestyle, how they can control their triggers, because many times people are not aware. They tell me that, ma'am, I don't know what is my trigger because I have daily headache. So first I tell them that let's not talk about this trigger. These can be the common things. You just try to change, but take this medicine. After 15 days, when the chronic migraine is gone, then probably they are able to see what are their triggers. Then we have to see whether patient is healthy, whether patient is thin built, whether patient is what kind of their clinical scenario is there. Obese patient, thin built patient, along with epilepsy, work profile, so that they are not daytime sleepy. So accordingly, we need to choose. If according to patient's finances, we can always advise them if they can afford and they do not want to take pills regular basis, then in those cases we can plan monoclonal antibodies or Botox therapy. And magnesium is, I think, is a very good supplement along with this prophylactic medication. And many people prefer these days, so that we can just stop our routine prophylactic medications after 2 to 3 months. Thank you very much. Any questions or queries?
Ma'am, there is a question in the chat box. There is a question in the chat box. What should be the duration of therapy in migraine, and what should be planned to withdraw the prophylaxis?
Okay. As I told, I think every person is different. There is no fixed duration of prophylaxis. Many people do very good after 2 to 3 months therapy. I always try that I should try to stop prophylaxis, people who are well controlled in 2 to 3 months. But yes, some people who had very chronic migraine, who had many triggers, they are not able to change their lifestyles because their family situations. There sometimes we have to give for 5 to 6 years, 6 months. And there are one category of people, about 20-30% people, who need one tablet of prophylactic medication for the long term. So if there are no side effects, we can continue for longer. But ideal therapy is 3 months or maximum 6 months, preferably. And once we feel that patient is well controlled, we need to tell them to work and control their triggers. If they are controlling, they have changed their lifestyle, then gradually we can make it tablet half, and we can withdraw over 2 to 3 weeks. That's how I do. And sometimes people do well for 2-3 years and they come back, ma'am, pehle bahut acha tha, 3 saal theek nikal gaye. Then there's a recurrence. Then we can always start, same medication, or we can change according to their situations.
Ma'am, what should be the treatment in pregnancy, migraine during pregnancy?
Migraine during pregnancy, prophylactic medication, as I told, that most of the medications are not safe, but as I've read the literature, magnesium can be given. Second thing, when there is acute attack, for acute attack, preferred medication is this metoclopramide, paracetamol metoclopramide combination that can be given when we want to avoid any NSAIDs or naproxen. Then we can give metoprolol tablet that can be given for 2-3 days, and we can just stop. And this magnesium supplement can still be given safely for some time whenever our patient is requiring. Otherwise, all other medications whichever are mentioned are not very safe, so we should avoid. We should tell the patient to change lifestyle.
Only 2 questions. Any other question anybody wants to ask, please put your question.
Thank you, ma'am, for the wonderful talk on migraine, diagnosis of migraine and management.
Actually, migraine is very close to my heart. I feel because I always try to spend time with patients who are having migraine. We get so many patients every day, but I feel we need to tell all these basic things because otherwise it doesn't seem to be a very serious kind of disorder because it's not life-threatening, but it's spoiling their life. There's a lot of comorbidity with migraine. You know, when you have headache, you are irritable, you are fighting with people, you spoil your relations, you're not able to focus on your studies, your work. So I feel it's very, very common disorder which need to be handled very gently, very in a proper way. You know, holistic approach is required to control migraine. So
Thank
I
you
was
very
happy
much,
to take this topic actually. Thank you.
Thank you. Thank you for the wonderful talk, ma'am. It's
Thank you
really
so much.
given a deeper insights.
Thank
Thank
you.
you.
And ma'am, thank you for giving me an opportunity to conduct this webinar. We will be doing more webinar on this part.
Thank you so much to the organizers. I'm very happy that we have discussed this topic, role of magnesium, all these medications. I think all these medications have their important role, and how to use, when not to use is very important to understand. Thank you very much.
Ma'am, thank you so much. Thank you.
Thank you.